number of participants. Beautiful.
Good afternoon, everyone. Welcome to our webinar this afternoon, supported by the North American Brain Injury Society. I do want to make draw your attention to the screen. NABIS is going to be having its first in-person meeting since 2020. And we'd like to invite you to not only attend, but submit abstracts. The submission site is open. And for today's session, we have Dr. Alan Weintraub and Dr. David Ripley, and I'm going to turn everything over to Alan to introduce the session. If you have questions, put them in the chat, and we'll be filtering those to Alan so that he can do Q&A at the end of the session. All right, enjoy. Thank you.
Good afternoon, everybody. I hope you can hear us well as we are teeing up Dr. Ripley's presentation onto your screens. I would like to introduce him and just state on behalf of IBIA and the North American Brain Injury Society, we are thrilled to welcome Dr. Ripley to this national webinar. And I must say, I've known Dr. Ripley for several decades, and he is an extremely well-versed, experienced clinician in the field of brain injury medicine, neurorehabilitation. He has held many positions in the past, formerly from Craig Hospital, the Rocky Mountain Regional Brain Injury System, and was the medical director of the brain injury program at Shirley Ryan, formerly known as up in Chicago. So Dr. Ripley is now the Chief Medical Officer for the HealthBridge Complex Care and Rehabilitation Network, and he still holds an academic appointment as an associate professor at Northwestern University's Feinberg School of Medicine. Would like to welcome Dr. Ripley, and if we could share his full screen, we can get under the way. If you could enter specific questions you have into the chat, we will collate those questions at the end and have Dr. Ripley address those. Thank you and welcome, Dr. Ripley.
Thank you so much, Alan, and I'd like to thank the committee for the invitation today. It's a pleasure to be speaking to everyone here. Just first starting off with disclosures, I really don't have any relevant disclosures to discuss, although the caveat is I do work in the post-acute rehabilitation space, and so some of my views are a little bit biased towards care in that setting. There will be no discussion of any off-label or non-FDA approved products. And I also would like to just go over the goals of the presentation. First, we're going to talk about the different settings where care is provided for individuals with brain injury in the United States, and apologies to any international attendees. This talk is really geared towards what's happened historically and where we are with the system of care in the United States. So there are some things that I think are only applicable to our system of care, and I'm hopefully going to share how we got to where all of these settings, how they developed, and how we got where we are today. So we'll talk about the history and the development of different settings of care where brain injury care is provided, demonstrate the contribution of each type of facility on the medical and rehabilitation care of individuals who sustain brain injury, and lastly, discuss some of the particular problems or concerns faced by these settings in the care of persons with brain injury. So any good brain injury talk is remiss without bringing up Phineas Gage. I think that this audience probably is very familiar with the story. Just real briefly, this was a gentleman who worked on a railroad construction crew in the mid-1800s and had sustained a severe brain injury when an explosion sent this long iron rod essentially under his maxilla and through his left frontal lobe. And really, without going into many of the details, this was one of the first situations where the correlation between particular areas of neuroanatomy and neurocognitive and functional outcomes was kind of began to be documented. His case was meticulously documented by a physician named Dr. Harlow, who provided his care and actually quite honestly saved his life. And so it was one of the first situations where a patient with traumatic brain injury, a severe brain injury, survived, and there was documentation and the case report to talk about how this individual lived afterwards. And the reason why it's important for this talk is it really, if you look at all the nuances of the case, this is a great example of what happens without the proper systems of rehabilitation and social care. Many of what we have today, when those aren't available, what can happen to an individual. So around the time that Mr. Gage had his injury, this is what the system of care for brain injury looked like about 150 years ago. You may have an injury, and at that time, you might be lucky if a hospital existed, but most people actually went home and were attended by a physician who may visit the home. And depending on the quality of care of that physician and that person's knowledge, your outcome was purely based on that, and to a large part, what kind of care your family could provide and how they could support you. That evolved into about 40 years ago to, as you can see, a much more complex system of care, where in the United States, we developed a pretty robust emergency response system. Acute care hospitals began evolving into acute care trauma centers with specialization in providing care for these individuals. And even within the hospital, there was subdivisions in where care was provided within the hospital. You have emergency departments where the patient was initially brought in and stabilized, sent to a neuro ICU where initial critical care was provided, mainly focused on saving the patient's life, then step down to a medical surgical ward. And then often patients would either go home or to, if their needs were large enough and it was available, an acute inpatient rehabilitation center of some sort. Some patients went on to a skilled nursing facility with the goal that most people were going home. And at the time, there was really not a larger system of care downstream for some of the needs that patients had for post-acute services and so forth. And fast forward to more modern times, you still have the structure of the emergency response, acute care trauma centers with their subspecialization. But in addition to acute inpatient rehabilitation, now you have specialized hospitals called LTACs. And many nursing facilities are actually becoming more and more involved in the rehabilitation, which we'll describe in detail somewhat later in the presentation. And then there was the evolution of these newer programs. There are different names for them: transition living programs, or community reintegration programs, where post-acute care was provided for patients who had the funding and qualify for them. And even after the patient discharged home, there was a series of things that happened primarily due to pressures, financial pressures on the system, where you had evolution of things like home health care, rehabilitation day programs, and then more extensive, robust outpatient therapy and vocational rehab programs. So referral patterns were noted. Dr. Weintraub mentioned that when we worked together at Craig Hospital, and at the time it was recognized that referral patterns were changing even then, to a number of patients were leaving the acute care hospital and going to these somewhat newer type facilities called LTACs. And there was an evolution or a change and shift in patient referral patterns that was evident back then. And I believe that this has only strengthened or become more robust and more widespread as the way that patients move through the system. And it became clear that it would be beneficial to have rehabilitation with brain injury, spinal cord injury expertise in the LTAC setting to kind of help make sure these patients were getting what they needed from a rehabilitation standpoint. The reason for the change in systems has been very complex. There have been a number of pressures. Again, many of them are funding based, and I just like to make a statement here that I'm not trying to present any particular political viewpoint. I know that this can be a very charged topic for a lot of people, and there are some very strong feelings. But really, I'm not trying to make a political statement. I'm just trying to provide information about kind of the evolution of these systems. So the funding system and changes in funding have really caused the creation of different industries within the care of patients with brain injury, and then also limited the care in different settings with greater regulations and so forth. Other pressures on the system include a change in the demographics. One of the biggest things that's happening over the last couple of decades is the aging of the population in the United States. We're seeing a shift in the average age of patients with brain injury. This creates additional challenges and pressures on the system for how patients flow from one setting to the other, and who is determined to be appropriate for what type of setting. There's also been change in care models and criteria for admission. There are more and more specialty care centers, not just for brain injury, but for other diagnoses as well. For instance, particularly for cancer care, there are a number of specialty centers just providing care for patients with cancer. And you're seeing more fragmentation within the field of rehabilitation based on the increasing specialty care that's provided in different centers. Then there's also been a change in injury characteristics, and much of this is actually really beneficial. Emergency medical system responses have become much more advanced. It's much more common now for patients to receive early intubation and paralysis in the field that provides, beneficial protection from secondary injury. There are also improved acute care protocols such as ICP monitoring and so forth in the ICU. So the end result is you have a greater need for more complex care for more seriously injured people than you did a few decades ago. It's just a fact that now patients are surviving more severe injuries that they wouldn't have survived a few decades ago. So again, it's great that we're advancing the care, but it is putting more pressure on the system and making it a lot more complex. So what are pros and cons to having this real complex system? Well, the pros really are the ability to provide more specialized care, because if you have a specialized care center, for instance, a neurotrauma hospital that only provides care to patients with brain or spinal cord injury, you're going to have greater expertise because that's all that the staff in that facility see. So you can really tailor the milieu and the equipment and the systems to specifically provide the needs for that patient population. This also has a financial benefit of potentially providing greater efficiency, because you're not having to reduplicate the type of equipment that's needed for more global patient services, and can focus on the type of equipment and care that those patients in your particular setting need. The cons, however, is as the system becomes more complicated, you're having more and more transitions from one setting to another. And as anyone who works in the medical field know, these transitions are the biggest potential source of error or omission, and often result in iatrogenic complications that possibly could have been avoided if you had a single point of care, someone who was following the case from beginning to end. This increasing complexity is also very confusing to family and caregivers and even patients, because most people who aren't familiar with these different systems are thrown into this mix with the, very complex systems of care. And they don't understand the nuances and the difference between these different systems. And there's frankly still some residual bias associated with some settings. I'm speaking primarily of skilled nursing facilities. There's often a strong feeling among patients and families, I don't want to go to a nursing home because of historical impression of those facilities. It's just a place where people go to spend the end of their days and so forth. The other thing is that certain aspects of care, when you have this transition between facilities, does increase certain types of costs, particularly the transportation between different centers. And often that that type of care and transportation is extremely expensive, particularly if you need life flight, air ambulance, those sorts of types of transportation. And then the converse to having the specialty care in specific care settings and having the equipment needed for just that particular diagnosis, it does result in the lack of ability to provide certain care needs, particularly when you have patients with more than one diagnosis or other complex needs. So how did we get here? When I talk about history of some of the settings, I love talking about history. It's kind of hard to understand, how we are what we are without understanding the history. And then from the history, you can kind of see how things evolved to where they are and give you insight on where we need to go. So I'm going to talk briefly just about the history of hospitals in the United States. Just to say that initially in Europe, hospitals evolved from primarily as religious organizations provide charity care. There's some really interesting hospitals in Europe that have gone back centuries, and most of them have been sponsored by religious organizations. And that is also true in the US. However, in the United States, many hospitals originated more as public health missions, from and were sponsored more by city government or state government as opposed to religious care organizations. So we kind of had this two tier or two pathway system for the development of hospitals. You still had some religious organizations that were establishing hospital care, and many of those still exist today. But a lot of these healthcare settings really evolved as a public health center or public health care, usually to take care of some specific diagnoses. So one particular hospital that was noted to be the first in the United States was Pennsylvania Hospital. This was established in 1751, and incidentally, Benjamin Franklin was a very strong advocate to establish this hospital. So many of these facilities were also designated to provide care to patients with particular types of conditions, particularly mental health, and I'll talk a little bit about that in a bit. One of the big things that was also notable about the hospitals in the US was that they were really established in part in many cities to be centers to provide medical education. That the hospital actually was started as a mechanism to teach physicians and nurses and medical professionals. Interestingly enough, early hospitals in the United States were predominantly created to provide care for the poor or socially marginalized. Most patients who had more financial means, middle class and upper class patients, still received their medical care at home, and the doctor would go see them in their home and provide care there. So really the majority of patients that were in the early hospitals were indigent or socially marginalized for some reason. As the Industrial Revolution occurred and society became more complex and more industrialized, hospitals followed along, also becoming more scientifically based in their practice, and advancing technology became available for medical care. And so between the end of the Civil War and the early 1900s, there was this rapid transformation of hospitals into expensive, more what we would think of now as expensive modern centers of science. And there was a shift away from kind of a religious charity-based care that historically these organizations were created to be. And as a result, a very competitive commercial market developed for hospital services. And there was a shift away from charitable organizations that were supporting hospitals. And this has really continued on today. Even a lot of the religious-based hospital organizations have really become private corporations. And even though there's a religious basis to their existence, they operate more like a business. During the Great Depression, many hospitals shifted from being privately owned to public institutions. These are more for specialty care and mental health services and so forth. And then one big factor that happened was the development of third-party payer system with the advent of Blue Cross, the first private health insurer in the United States. And all of a sudden, this had a separation between the person who was consuming healthcare and the person who was paying for healthcare. World War II was a great event in the shift of healthcare provision in the United States. The federal government became more involved in healthcare, so it began to move from community-based and state-based systems to more federally based programs. And in 1947, there was a study to look at the need for more public health care services across the U.S. And it was determined that there was a significant there's a need for more hospital beds in the U.S. And the Hill-Burton Act actually started providing funds for construction of community hospitals throughout the country. Interestingly enough, there was a study that actually showed the growth of the population versus the number of hospital beds. And there was a time period where it was felt that we actually overbuilt the number of hospitals in the United States. There were too many beds. However, there are other things that kind of affected the development and the evolution of hospitals in the United States. National Institute of Health, again, expanded in the 1950s, which provided now funding for hospital-based research, further changing hospitals into more scientifically based organizations and looking at evidence-based care and so forth. In 1965, Medicare and Medicaid acts were passed, which provided payment for poor and elderly. This again provided additional payment systems for hospitals and stimulated further growth. And then during this time, there was a demand by the population for greater quality of health care and increasing technology. And this resulted in the need for more professional nurses. Up until this time, many nurses were still trained in small hospital-based programs that weren't necessarily scientifically based. And that changed with the change in nursing programs to bachelor's degree programs and advanced graduate degree programs. So you now have a core of professional nurses with increased expertise in caring for more complex care patients using advanced technology. The growth of the number of hospitals and increasing complexity of care provided began to result in increasing costs. And of course, that started resulting in increasing regulation. Medicare began to attempt to contain these costs. The biggest factor the thing that they did to try to do this was implementation of a prospective payment system, which again provided care or funding for care based on diagnostic groups. And so the hospital would get funding for the diagnosis of the patient, and it was up to them to really figure out how to provide the care they needed based on this sort of lump sum payment. However, this also resulted in a rapid growth in for-profit hospital systems as this became more business organization, and then more hospitals united and were purchased to form larger organizations. And we're seeing the same shift today, probably pressured by the fallout from the COVID pandemic, where many smaller community hospitals were closing and being bought out. Efforts in cost containment continued in the 1990s with the formation of health maintenance organizations and trying to shift care to lower cost alternatives that have been created, such as skilled nursing facilities, ambulatory care centers, and outpatient centers. The Affordable Care Act also has had great pressures on hospital systems. One of the aspects of the Affordable Care Act was the formation of affordable care organizations. And so now what has resulted in many markets, this is actually quite developed here in the Chicago area, where hospitals and hospital groups are partnering with more post-acute providers such as skilled nursing facilities and inpatient rehab facilities to provide a more system of care within different areas. And so hospitals become increasingly privatized, more absorbed in multi-facility companies. Then COVID-19 has put tremendous financial pressures on healthcare with increasing costs and labor shortages and so forth. So that's kind of how we are where we are with hospitals. I'm going to shift and talk a little bit about skilled nursing facilities. Skilled nursing facilities, historically in the US, and I think for more well-to-do families in other countries worldwide, families were responsible for the care of older individuals or those with disabilities in their home. Of course, patients, people who couldn't afford or didn't have family support were relying on charity care, and in many communities, poorhouses were created, and that was the term for them, to assist people with disabilities or older adults who were indigent. And so these people were relying on charity care for the care provided. Some of these early poorhouses became specialized care for specific populations. This was really robust in the late 1800s, early 1900s with tuberculosis, and then later with polio centers. That's became an area where many people went to receive specialty care for those conditions. There was also a number of veterans homes that were established to provide care for injured soldiers. And then a number of these facilities evolved to care for people with mental illness. In the early 20th century, there was an attempt to improve quality of care. State-sponsored institutions were developed to care specifically for patients with mentally ill. In 1935, the Social Security Act actually really created the skilled nursing home industry as we know it today. All of a sudden, older people now had funding for care, and care in these facilities were paid for. So it really created the whole industry. And the complexity of care that was provided in these facilities mirrored what was going on in hospitals as the care in hospitals became more scientifically based and complex to a lesser degree. This also occurred in many nursing facilities. The passage of Medicare in the 60s also increased availability for funding for this level of care and subsequently increased the need for beds. And this has led to greater specialization of certain nursing homes, led to the provision of increasing levels of care provision, such as hospice care, palliative care, and then rehabilitation care in the form of therapy services that were offered in these settings. And as the hospital industry, the nursing home industry is also organized and become more corporatized, if you will, owned by larger companies with chain ownership. Other long-term care facilities have evolved as a result of this also. Many what we call assisted living now actually mirrors probably more what the early nursing homes were, as places where more is just a place to live for someone who needs a little assistance. Another evolution is in memory care facilities, that are specifically not rising to the level of medical care that the nursing home needs, but for those patients that have more dementia processes. Additionally, an increasing number of facilities have focused on providing rehabilitation services. If you look around the country, many nursing homes have the term rehabilitation in their names, and began catering to shorter term stays with focus on providing therapy services rather than just a place for people to go. And so actually the majority of skilled nursing facilities in the US now provide rehabilitation services. This is kind of a breakdown of the types of patients now that exist in nursing homes. You have the overall nursing home population. You'll have patients that are kind of globally referred to as short stayers patients, and then the long stay patients. Short stayers are people that are temporarily ill or hospice type care, then rehabilitation, functional improvement, with the idea that these patients are ultimately going to go home, are people that are temporarily medically unstable. They need a little more time before they're able to be cared for in the environment. Long stayers, again, they're called residents, and depending on the state you're in, you'll see these different terms, and often depending on the bias of the state organization, a lot of nursing facilities will use the term resident still to refer to the people staying there. Residents tend to be primarily cognitively impaired, cognitively and physically impaired, or physically impaired, such to the point where they're not really good, quote, rehabilitation candidates, but they're more in a maintenance care. And kind of like the hospitals, Affordable Care Act resulted in creation of accountable care organizations, which I mentioned. Many skilled nursing facilities are partnering with hospital organizations to provide a full continuum of care. COVID-19 really hit nursing homes very hard. Many of the other hospital systems are recovering well, but SNFs are recovering at a very slower rate, and the median operation margin for SNFs has really taken a hit, and now a lot of them are losing money, and occupancy rates are down. Even the facilities that are not having these troubles financially are having tremendous problems with staffing. So the next area I want to talk about real quick is we're going to talk about long-term acute care hospitals, also called the LTACs, and then I'll finish up with inpatient rehab facilities. LTACs are kind of interesting hospitals that evolved as a result of changing legislation when the prospective payment system was introduced in the 1980s. It was recognized at that time that there were certain conditions or care for certain people that was provided in certain types of organizations, and we're primarily talking about patients that needed long-term ventilator care that really didn't fit under the DRG prospective payment system. And so the term long-term acute care hospital, LTACs, was created to protect these facilities. And originally there were 40 facilities that were kind of termed chronic disease hospitals that were, I guess, grandfathered into this LTAC system. And this resulted in a rapid growth in this particular industry. As of 2014, there were over 400 LTACs nationwide in the United States. One of the criteria is that these patients required intermediate to long-term care, primarily ventilator management. And these types of hospitals are defined as hospitals which have an average inpatient length of stay of greater than 25 days. So it was otherwise pretty poorly defined what LTAC hospitals would provide care to. This may have resulted in different LTACs operating with targeting different patient populations. But the goal was to make sure that the average length of stay was greater than 25 days. Recognizing that this was potentially a source of misuse of funds, or in attempts to provide cost containment, Medicare began providing greater regulation towards what type of patients qualified for care in these facilities. And so they've recently become under extreme scrutiny due to costs. My personal feeling is that these systems provide a great service, and it's not as simple as just looking at these different systems and saying, oh, this one's wasteful and that one's not. There needs to be a solution for the provision of care that is financially feasible for these types of patients. So again, like mirroring other healthcare organizations, many LTACs have become owned by large hospital corporations. In the United States, there are really two very large LTAC corporations that are existed, that most LTACs are a member of one or two of those companies. History of inpatient rehabilitation facilities is also very interesting. It started kind of in the 20s with recognition that patients with disabilities really deserved and needed additional support. In 1920, Woodrow Wilson signed the original Vocational Rehabilitation Act. And then Franklin Delano Roosevelt was, a huge influence on the field of rehabilitation as we know it. When he contracted polio in 1921, of course, he was a person with great means, and he purchased a facility down in Georgia called Warm Springs Rehabilitation Center. This was a popular warm spring spa that originally was kind of a vacation destination for many people from the north. We'd come down there in the winter, and he saw the benefit. He received personal great benefit from the exercises he received in the pool there, and developed an into rehabilitation program for patients with polio. Furthermore, FDR signed the Social Security Act in 1935, providing assistance to people with disabilities. World War II was a huge factor influencing the development of rehab services in the United States. Many returning soldiers with injuries benefited from rehab services through the Veterans Administration, and the brand new field of PM&R was growing, and many of the early pioneers such as Rusk and Magnuson, Zeter, and Cruzen also that saw that civilians could also benefit from the care that was provided to veterans, and new rehabilitation centers began to be formed. When the Hill-Burton Act was passed to build all these new hospitals in the United States, this didn't provide provision for building rehab hospitals, but later on in the 50s, amendments were passed to start allowing construction for rehab facilities. And then in 1972, Medicare coverage expanded to include disability services and inpatient rehab, which then further supported the industry. HCFA, which was the predecessor of the Centers for Medicare, then worked with leaders within the American Academy of Physical Medicine and Rehabilitation to define the characteristics of inpatient rehabilitation facilities. And this is where a number of the rules that we know today kind of originated from, such as 3-hour rule and so forth. Again, the prospective payment system had a huge influence in the 80s on many patients being now moving away from acute care hospital earlier, because now hospitals are under pressure due to DRGs, and moving those patients to inpatient rehab facilities to both provide the care they needed and protect their financial status. As time has passed, greater regulation and scrutiny in IRFs has also created some rules such as a 60% rule and other needs for qualifying stay and in acute care. So as a result of all that regulation, these systems of care of IRFs kind of evolved to what we know today. Many programs have developed that provide specialty care specifically for certain conditions, such as spinal cord injury, stroke, and particularly brain injury. And this resulted in a proliferation in the 1990s and 2000s. Again, there was private equity-backed large corporation funding for certain rehab facilities. And the ACA has seen the formation of many ACOs, which include inpatient rehab facilities in their system. Then briefly, I want to talk about post-acute rehab facilities. These are the transitional living facilities. These really started in the late 1970s due to recognition for the need for continued services for individuals with brain or spinal cord injury, for more vocational-based services or return to the community that wasn't really typically the focus of care in an inpatient rehab facility. As the prospective payment system put pressure on inpatient rehabilitation facilities, this became also a discharge disposition. Later, as insurance plans became more limited in what they would provide, one big act that happened, particularly for brain injury, was insurance companies began carving out cognitive rehabilitation as an unpaid service. And so much of the care then shifted towards workers' compensation. A lot of these organizations also have become larger multi-center or corporation-based. So what are the differences between these types of facilities? Just real quick, because I want to keep an eye on time. Inpatient rehab, inpatient acute rehab, these usually occur either in a hospital floor or a specialized brain injury unit. The patient may be a freestanding unit. The patient must be medically stable and able to tolerate 3 hours of therapy daily, require at least 2 disciplines of PT/OT or speech therapy. Average length of stay in the rehab hospital is 4 to 30 days with a reasonable expectation that the patient is going to be discharged home. Skilled nursing facilities or inpatient settings, usually outside of a hospital. Patient again must be medically stable. Therapy disciplines are delivered at a lesser intensity. Average length of stay is 30 to 60 days. For long-term care hospitals, these are medically complicated patients, usually requiring ventilator care and cardiac support, and length of stay has to be greater in average for 25 days. If facilities average length of stay falls below 25 days, then the hospital risks losing its accreditation as an LPAC. Other settings where TBI rehabilitation is provided include home health. This is health rehab in the home, day treatment, community-based programs, outpatient rehab, and then again, we mentioned post-acute residential. These are for patients. Usually they're more behavioral challenged patients or cognitively challenged patients who don't have the need for the intense medical care, but still need rehabilitation and support. I'd like to acknowledge my colleague Heidi Fusco, who at Rusk, who let me borrow this slide. Criteria for IRF, the big things are that therapy needs to be provided in at least 2 modalities. They must actively participate 3 hours of therapy at least 5 days a week. The patient must be sufficiently medically stable and require supervision by a rehab physician. Additionally, the 60% rule was passed to try to more regulate the types of patients that were going into inpatient rehab facilities. And so for the 60% rule, this was tried to change it for a period of time to 75%, but came back to 60%. Just said that the 60% of the patients admitted to an inpatient rehab facility must have one of these qualifying diagnoses. Of course, brain injury is one of them, stroke is another. And as a result of this, you've seen a shift in neurorehabilitation being a much larger proportion of patients admitted to inpatient rehab facilities. A quick comment on the 3-hour rule. There was a meeting in 1978 between the Peer Standards Review Organization, the HCRA, the predecessor to the CMS, to come up with criteria for inpatient rehab. The main reason for discussing 3 hours was that in kind of a group discussion, they were talking about what is really kind of the global difference between inpatient rehab type of therapy that was provided in skilled nursing facility. And they said, well, about 3 hours of therapy is what is recommended. There have been a number of studies, both in and outside of brain injury, looking at validating 3 hours of therapy with very mixed results. There was actually a lawsuit to challenge this rule, and even the law says the 3-hour rule can only be used as a screen, not as a final determinant for payment of services. However, many organizations still act as if the 3-hour rule is hard, fast in law. It's interesting that the first discussion of 3-hour rule by CMS came only in 2010. It was only there to demonstrate the typical intensity of therapy provided in the and just this statement, the medical necessity of inpatient rehab should be based on individual acts and circumstances of the case and not on the basis of the threshold of therapy time. However, this is rarely the case, and denials are often based on therapy time, as those of us who work in the system know. The CARES Act provided brief respite from this, but as that transitions out, the 60% rule, the 3-hour rule will likely become more in effect. There's some really interesting trends for inpatient rehab facility. Over time, the lengths of stay decreased from the early 2000s until recently, to where the average length of stay has now remained relatively consistent, about 17 days in inpatient rehabilitation facilities across the country. Over the same period of time, cases admitted to IRFs have become increasingly complex. And this was originally done as a cost containment measure. But what's been seen under PPS that the costs of care, the payments have increased more than costs. And so there's a pressure that CMS will again look at the ways to contain costs and put more pressure on this. LTACs, again, historically evolved as sites for patients who need prolonged ventilator care, can be freestanding or located with another hospital. To qualify for an LTAC stay, patients must have an average length of stay of greater than 25 days. They must require daily intervention by a physician and cannot be effectively managed at a lower level of care. And they now must meet certain medical criteria. Ventilator weaning still is a big one, but cardiac monitoring and some of those things, IV therapies also are qualifying. And skilled nursing facilities have evolved into more areas where more rehabilitation services are provided in the U.S. And the term subacute rehabilitation kind of evolved. Now, I'll mention that there really is no regulation or legal term for subacute rehabilitation, with the exception of the state of California. And there may be other states that I'm not aware of, but there is a subacute rehabilitation designation in California. So there are specific facilities for that. So when we talk about subacute rehab, we're generally talking about therapy service provided in a skilled nursing facility. Typically, these patients receive 30 to 90 minutes, 3 days per week. Lengths of stay in these facilities are longer, average 60 to 90 days. There's really not any rules on therapy provision, although another shift in the insurance industry has seen that they're starting to apply the same rules towards qualifying stays in SNFs as they have for inpatient rehab facilities. So they are denying care or not funding care for patients in these settings for the same reasons that they're not making appropriate progress in therapy and so forth. Other differences is that these skilled nursing facilities may outsource the therapy services, and there's no requirement for rehab physician oversight and no requirement for an interdisciplinary team approach. So what's the true difference between IRF, LTAC, and SNF? I would say really focused on inpatient rehabilitation. The primary difference is the interdisciplinary team approach led by a FAAPM&R physician. Somewhat the amount of therapy is a factor. Again, there is the 3-hour rule. And in general, most patients in inpatient rehab will receive more hours and minutes of therapy than they do in the other settings. However, this is variable based on the particular facility. There are some skilled nursing facilities that actually provide 3 hours therapy a day and so on. Patients tend to be more medically stable in the SNF setting than in the LTAC or inpatient rehabilitation setting. In order of stability, patients tend to be most stable in SNF and least stable in LTAC. Nurse-patient ratios are also different. These tend to be higher in LTACs and IRFs and lower in SNFs. Community reintegration programs, post-acute programs. These are traditionally for traumatic brain or spinal cord injury. Patients have need for 24 on-site supervision, but generally not the same need for nursing care and medical oversight. They can have relatively intense therapy programs, but the focus of therapy is often more towards community reintegration and vocational programs. So real quick, I'm going to revisit this slide and talk about brain injury. Again, in this setting, the acute care, this really has remained much the same, even though technically the care that's provided is much more sophisticated now with higher equipment, higher surgical intervention than the past, and so on. So this site is really designated for acute medical stabilization, and then transition as early as possible in one of these two settings, or even to a skilled nursing facility. And generally speaking, patients in LTAC are where patients go when the needs are really complex. They operate under the same regulations as acute care hospital for the most part. So one of the things that's a big problem is patients who need restraint. LTACs are able to provide restraints, whereas even though technically many skilled nursing facilities could provide restraints under state regulations, they really shy away from it and often will turn down patients who require restraints. again, many inpatient rehabilitation facilities are the same way. So inpatient rehabilitation really has become much more streamlined into the quick, hard push to get patients into the home setting or potentially into a transition living program. And then a lot of the care is being provided now downstream. So each one of these facilities provides a benefit to the system of care, and really provides a unique, special type of service that can improve the quality of care. If somebody really receives a high quality intense care in each of these settings, it can result in better outcomes. Some particular challenges for brain injury: we mentioned ventilator dependent. That often most inpatient rehab facilities will not take patients on ventilators. So most skilled nursing facilities also will not take patients on ventilators. So they'll end up going to an LTAC instead. Weight-bearing precautions are another particular issue. Often patients can't do inpatient rehab or won't get approved for inpatient rehab if they got weight-bearing precautions. Behaviorally complex patients are often one of the biggest challenges. And then one of my special kind of pet areas is patients with disorders of consciousness. Again, being able to participate in 3 hours of therapy often limits their ability to go to inpatient rehab, even though the expertise that those patients would need really usually is in that setting. Other medical comorbidities, things like need for hemodialysis, and other special, advanced IV administration, things like that often limit what type of setting the patient can go in. Real quick, I want to talk about site neutral payment. This actually is the proposal that keeps being brought up. I think it's been proposed 5 times now before Congress. It keeps being shot down, but there's a strong chance that this will come again. And what this proposes to do as a cost savings measure is to kind of level the playing field and get rid of all the different designations of these different post-acute facilities, and create one payment system for all post-acute facilities, which will dramatically change how rehabilitation care is provided and post-acute care is provided as we know it. So in summary, the care for patients with neurotrauma has become extremely complex. Care for brain injury now requires multiple points of care in different settings. Transitions of care are from one setting to another are often points where problems occur and things get missed. This is one area where I would suggest really is the benefit for PM&R and rehabilitation physicians to have a presence in all of these different facilities to help guide the care and make sure transitions are appropriate. There's a lot of opportunity for rehab professionals to play a role in alternative care settings other than inpatient rehab. And I'll stop there. I went over time. I apologize, but I think we have time for a few questions if anybody has any.
If I do not see at this time any chat room questions, feel free to put 1 or 2 in. We have 3 minutes. In lieu of that, Dr. Ripley, I want to ask your thoughts on the concept of a centralized versus what you've described here, which is a very non-centralized injury to life system of care. Clearly, it's easy for us to see through this presentation why there's difficulties with access, why care becomes fragmented, and why especially long-term psychosocial outcomes are significant. When 4 out of 5 severely brain injured patients really do not have a matched insurance funding to access and work their way through this system of care, which has a very large business-driven, corporate-driven component. So what are your thoughts on that? And I think it might tie into some of the legislation that you introduced.
Yeah, I think the evolution of more specialty care systems, like I was saying, has resulted in advances in care and improvement in the quality of care. But often it becomes so specialized that there are certain things that aren't provided. I would say that one of the biggest things is a challenge for this patient population because they really don't fit neatly in the way our insurance industry is, and insurance benefits, our policies are written today. And I think some of this is probably has to do with the fact that in the US, the health insurance industry is primarily driven, the payer for that are, employers. And so the policies are really designed between human resources departments and the healthcare companies. And again, when the focus goes on, providing care for a broad population, you've seen a shift in the insurance industry from providing really care for patients with critical illness and injury. That's what original, health insurance was designated for, provide payment for that kind of care that you couldn't afford out of pocket. And over time, insurance has evolved based on consumer demand to provide more and more care for things up front, like doctor's visits and, pharmacy and things like that. And, well checked, patient checks, that historically those were services that were just out of pocket. And your insurance was there to provide care if you had a catastrophic illness or injury. And as the insurance industry has shifted to provide more care to those upfront services, what's eroded is the back end, more services for critical care. And that's resulted in this, additional actions like need for prior approval and so forth, which also, I didn't talk about this a lot in the presentation, but provide another layer of complexity to patients moving through the system. You have to have, approval for the next setting of care, and often that is reviewed by, a panel in the insurance industry. So as far as ideally, I'd love to see the personally, the slate sort of wiped clean and have the medical community take ownership again of patients in the system, and have more of a role to play in what's appropriate, and who needs to go to what different level of care. There's some interesting healthcare systems that are evolving in this area. University of Pittsburgh has a kind of an interesting model. It's sort of like an HMO. They have their own insurance company that provides care for many people in that community. And so as a result, since it's their own insurance company, so to speak, they do communicate more with the acute care or the attending physicians to say, hey, this patient kind of fits out of our box, so to speak. What's different about them that we need to, make an exclusion or, rationalize a different level of care than what they look like on paper. And as I understand from, physicians who practice in that system, it works quite well when you have these kind of outlier cases. And brain injury for sure is an outlier, right? This is the kind of particularly severe brain injury that doesn't fit well within our insurance system. So
There's two important questions here. There's time for 30-second responses. Your thoughts on provision of treatment via online platforms?
Oh yeah, this is a great new technology. I actually think that you're going to see more and more rehab industry, inpatient rehab facilities or post-acute rehab facilities start utilizing telehealth and online-based platforms. And there's actually a couple of companies that evolve now. There's one company that is providing more ortho-based rehab services on an app where you get a prescription of therapy. I think that this is an ideal platform or mechanism to provide care, particularly for rural patients that don't have access to some of the expertise. So I think you may see this as a big shift in the field in the next coming years. So if one of the good things, if you will, that came out of the COVID is, telehealth has become kind of more solidly fixed in our system, and is going to become a bigger and bigger player.
There's a question on communications and handoffs, if you will, amongst the centers. Creative ideas on that.
Well, different things have been tried. I think that the most advanced systems still exist in the workers' compensation industry, where you have, case managers who are responsible for monitoring the patient as they transition between different settings, and they're really kind of the gatekeepers. There's certain specialty care, what we call centers of excellence that kind of provide the same thing along with work comp and help follow those patients long term. Again, I feel like this is a natural role for rehab physicians to be the ones that are providing that coordination of care. So I think that's a real role for us to play.
And the last question here is any advice for the frontline professionals when they're advising a family, if you will, on proper placement with forethought to long-term outcome? And it's easy to place somebody into an LTAC without thinking about that's going to be a system that may or may not benefit them relative to what their outcome and long-term needs are going to be.
Right. And one of the issues that occurs in many LTACs is they do a great job with the acute medical care and ventilator weaning, though many of them don't have neurotrauma expertise. And, since this is a destination for a lot of brain injury patients, there's things that happen in those settings that are kind of natural internal medicine responses to situations that we know are not ideal for a patient with brain injury. So I hope that PM&R, and I expect that the field of PM&R is going to evolve to more roles within these different care settings other than just IRF. So that's what I hope and expect to see in the future.
Thank you kindly, Dr. Ripley, and thank you for all the participation. This presentation will be available online in the next 3 to 4 months, and we look forward to seeing everybody at ABI 2024 in Las Vegas. Thank you, Dr. Ripley.
Thank you, everybody.